Hello, and thank you for joining us. Welcome to Evexia Diagnostics' special live webinar event. My name is Joshua Kroll. I am the Director of Sales and Marketing for Evexia Diagnostics, and also your host and moderator. We are excited to have you with us today for this important presentation, which is focused on COVID-19, what we know now, and making informed choices moving forward. I am pleased to be joined by our very special guest, Dr. David Brady, who will be offering answers and insights regarding this pressing topic. We will begin with pertinent information from Dr. Brady before moving on to some Q&A. I ask if you have questions that you would like addressed, please type it into the chat box located in the right-hand column, and we will do our best to get to them all. Now, before we get started, I would like to provide a brief introduction for Dr. Brady. Dr. Brady has almost 30 years of experience as an integrative practitioner and over 25 years in health sciences academia. He is a licensed naturopathic medical physician in Connecticut and Vermont, is board certified in functional medicine and clinical nutrition. He is also a fellow of the American College of Nutrition and completed his initial clinical training as a doctor of chiropractic. Dr. Brady is the Chief Medical Officer of Diagnostic Solutions Lab and Designs for Health. He is the former Vice President for Health Sciences and longtime Director of the Human Nutrition Institute at the University of Bridgeport in Connecticut, where he still serves as an Associate Professor of Clinical Sciences. He has appeared on the plenary speaking panel of some of the largest and most prestigious conferences in the field, including IFM, ACAM, A4M, ACN, IHS, AANP, AIHM, and many more. He is in clinical practice at Whole Body Medicine in Fairfield, Connecticut, specializing in functional, nutritional, and naturopathic medicine. And now, without further ado, I'd like to welcome Dr. David Brady.
Oh, thank you. I appreciate you inviting me, and I'd like to thank everyone for joining us tonight, taking time out of their busy schedule, and hope to make it worthwhile reviewing some of the latest things on what we're going through with this COVID pandemic, and we'll take it from there. We're going to get started, everybody, and I put together this material right through this afternoon, so hopefully it's as current as it can be. We're going to talk a little bit about COVID-19 and SARS-CoV-2, and of course they are different things. I think everyone probably listening knows, but just for definition's sake, when we reference COVID-19, of course we're talking about the clinical respiratory disease syndrome that can be caused by SARS-CoV-2, and SARS-CoV-2 is the virus. So we're going to look at some of the mechanistic underpinnings of this virus and how it does its dirty work, and then we're going to pivot into testing options and a review of the different controversies and the different scientific elements involved in the testing for both COVID-19 and for the virus itself. You guys heard my bio and intro. I should have given you the shorter one, but just my disclosures, I am the CMO of both Diagnostic Solutions and Designs for Health. So this is the latest as of today at about 1 o'clock in the afternoon. This is the Johns Hopkins University statistical dashboard on the pandemic. And you can see the total confirmed cases worldwide are right about 9.5 million. Total cases confirmed in the US just short of 2.4 million. And the even more important number, global deaths, almost 500,000, and in the US about 122,000. So this is obviously a significant issue that we're all dealing with in our lives, and certainly as healthcare practitioners, we're dealing with it in a even more acute way with all of our patients that are looking to us for advice, our family members, and many others, and we'll touch on that subject as we go. Let's just talk about the virus SARS-CoV-2 and why it's been so problematic, particularly as it is compared to, let's say, the first SARS or SARS-CoV, the SARS epidemic in the early 2000s. The SARS-CoV-2 virus is a little bit of a different animal. It's a coronavirus as part of a broad family of coronaviruses, but it has some, uniquenesses to it. It has a spike protein similar to SARS-1, but it also has something known as furin cleavage sites that allow it to basically enter all types of cells, making it very, very easily transmissible. And in fact, it's estimated to be about 1,000 times greater in virulent transmissibility than the SARS-1 coronavirus. So therefore, it has affected many, many more people worldwide. So these coronaviruses, kind of are named coronavirus, is pretty evident just by looking at the graphic displays of them. Kind of looks like a crown going around the whole viral particle, and this crown effect is really created by these unique spike proteins. And these spike proteins in SARS-CoV-1 have an affinity to dock in ACE2 receptors, so angiotensin converting enzyme 2 receptors. And therefore, wherever there's tissue with cells that have a high prevalence of ACE2 receptors, you can get a great deal of penetrance of the virus into those tissues. Unfortunately, those tend to be very important tissues, things like lungs, heart, kidney, brain, and the GI mucosa. And we'll talk a little bit more about that later. So the virus can dock from the spike protein to the ACE2 receptor, and from there develop a sort of interaction with the actual cell membrane, between the viral membrane and the cell membrane. And part of that occurs because of something called furin cleavage. Furin or other enzymes can kind of break off the spike protein and expose fusion peptides from the virus that kind of create an attachment or a channel between the viral membrane and the host cell membrane, which is where the genetic material can enter the cells, and the cells can be hijacked to replicate more of the SARS-CoV-2 virus. But as we said, the virus can actually enter through furin cleavage in cells that do not express much in the way of ACE2 receptors. So it's a very, very sinister organism, and therefore it has penetrance into a wide array of tissues throughout the body. Therefore, there's a wide array of potential clinical presentations and symptoms that can be created by the pathogen. But of course, the one that gets all of the press and the attention is the acute respiratory distress syndrome and acute lung injury. This is what drove people into ICUs and into critical care, and eventually onto ventilators, many of them, and to very poor outcomes, including in the vast majority of cases that people went onto ventilators, they ended up unfortunately succumbing to the infection. So this acute respiratory distress syndrome is probably the most acute and serious presentation or symptom of the virus, but by no means is it the only one. But there are lessons to be learned in this whole phenomena of ARDS and ALI, because this occurs only in situations where there's really uncontrolled progressive inflammation that occurs in the tissues, in this case in the lungs, which causes an acute diffuse alveolar infiltration and damage. And that's where you've heard in the literature and even in the media things about these ground glass opacities that can be seen in the lung. So there are changes that can be apparent in the lung, but they don't seem to look exactly like we see in other kind of viral pneumonias per se. There's not as much obvious consolidation. Sometimes the lungs look weirdly fibrosed, full of these ground glass opacities, but yet without recognizable classic consolidation. And it's not the only kind of oddball about the disorder. The clinical presentation is different. Many of you have probably read about the happy hypoxia phenomena, where people in the emergency room come in, and when they do oxygen saturation levels on them, they're remarkably low, in the 70, 60%, in which case most people would be panicked. They would be feeling like they're about to die, because usually when you're hypoxic, it creates a lot of anxiety and angst and feelings of doom in an individual. But these people are on their cell phones texting. So that there was a weird phenomena going on at the level of perfusion and oxygen exchange, which really is still puzzling vascular biologists and pulmonologists. and people who study respiratory diseases to this day. But we're going to talk about some of the things that have been learned about that since we first kind of started watching these patients as they went through their clinical progression. One of the things, though, to know is that this kind of uncontrolled inflammatory storm or cascade that you've often heard of as the cytokine storm, really the first domino to fall from a metabolic and a physiological standpoint is the activation of the NLRP3 inflammasome. Now, this is an inflammasome that can be activated by viroporins produced by the virus, which we'll talk about in a minute. But when NLRP3 is activated, it causes the macrophages and other immune cells to produce a robust amount of interleukin-1 beta. It's a really potent pro-inflammatory cytokine that really sends the dominoes just falling through the whole cytokine expression of the patient, particularly if they have a genetic susceptibility to go down this road. Now, we all know the majority of people who get infected with SARS-CoV-2 do not go down this progression to cytokine storm, but some people do. And when they do, some people go down it rapidly and really progressively. So we're still trying to mine the genomics of these people to try to figure out what is the constellation of SNP aberrations or other kind of genomic patterns that we might be able to predict who this might happen to in the future. But that's still work that's ongoing. And they've looked a lot at ACE2 receptor SNPs and different cytokine production SNPs, and there is some information that has been learned, but not enough to yet fully be able to predict who this will happen in. Of course, the more you have underlying chronic health conditions, obesity, hypertension, anything that's a pro-inflammatory condition, the more you're likely to go down this pathway. But we've even seen, unfortunately, young, healthy, not chronically ill individuals go down this pathway rapidly and actually die from the disorder. So what is it that is causing this activation of the NLRP3 and in turn the interleukin beta and then down into the cytokine storm event? Well, the virus actually produces certain proteins or peptides called viroporins that activate these inflammasomes. And they do so strategically in order to facilitate wider spread rapid viral dissemination. Even though these cytokine expressions are meant to control infections and viruses, inclusive of viruses, the virus almost uses this and hijacks it in a way to widely disseminate their presence into various tissues. So the virus actually can produce a viroporin known as ORF3A, and that seems to be the little bugger that really activates that NLRP3 inflammasome in the host. But other proteins or peptides expressed by the virus can do this as well, including some of the envelope proteins, sometimes referred to as E proteins on the virus. Now, when we look at what happens when people get exposed to the virus, it's very, very interesting that the death rate by age group is striking. As you can see here, the older you are, the higher your risk is. Now, that may not surprise many people. It's pretty intuitive, right? People, when they get elderly, are not as healthy, not as robust, and they're metabolically, not as able to deal with significant insults. Their immune system's not as strong. They're more likely to have cardiovascular disease, hypertension, and you name it. But this prevalence of death rates by age is much more striking than would be accounted for by that phenomena alone. There seems to be something physiologically, metabolically unique about people in these age bands versus young people that creates this striking difference by age. And I'm sure many of you have heard about this. I just wanted to talk about it a little bit more. It's interesting that it correlates very strongly with the level of melatonin through the age bands. Young people, children, have very, very high melatonin levels, and then it decays as we get older. And it's remarkably lower in elderly people. In fact, young, healthy, children and young adults can have 10 times the rate of melatonin being produced per day than elderly, healthy individuals without chronic disease. And it's interesting, we think of melatonin clinically mainly to help people with sleep as part of the circadian rhythm signaling, and that's true. But melatonin is a very potent and strong immune modulator, and in fact, it's used at higher doses in cancer therapeutics, in autoimmune conditions, except for rheumatoid arthritis, which it's contraindicated in, for these very reasons. And lo and behold, there's a lot of literature out there on melatonin levels by age, but also melatonin levels in modulating inflammatory cytokines, including in septic shock syndromes, which is your classic research model for cytokine storm. In fact, melatonin is a potent inhibitor of that NLRP3 inflammasome. In fact, it's a direct target of that inflammasome, or that I should say the inflammasome is a direct target of melatonin. So melatonin can potentially be used therapeutically in patients, and we've actually been using it all through this pandemic for this very reason, in a proactive way, in a prophylactic manner, and I'm sure many of you have been using it with your patients too. So regardless of whether they had problems sleeping or not, all of my patients who wanted support for their immune responses, should they be exposed to COVID, were being put on at least 3 milligrams of melatonin on a nightly basis to kind of hedge the bets against them going down this domino sequence of cytokine storm. Now, most of the data on melatonin in modulating septic shock and cytokine storm has been done in animal models, mainly rodent models, but there is some limited amount of information in human models as well. Now, one of the things that inhibits NLRP3 strongly is ascorbic acid or vitamin C and nitric oxide. And of course, ascorbic acid in high doses stimulates the endogenous production of nitric oxide. So would something like the ingestion of high-dose arginine, for instance. But you know, we've all heard about the IV vitamin C drips being used in COVID-19, and this is the mechanism by which they're acting. There's a multitude of mechanisms, but one of the main mechanisms, of course, is to produce more nitric oxide and to neutralize NLRP3. But it can also work in just reducing oxidative stress, regulating hypoxia signaling, increasing mitochondrial membrane potential, modulating furin expression, and immune defense systems in general. And, you know, we've known for a long time the modulating effects of nutrients in immunometabolism and the role of macrophage NLRP3 in cytokine storms and in septic shock syndrome, and how nutrition and nutrients at therapeutic levels can really modulate things pretty significantly. And we're going to talk about a few of those things before we get into testing. Now, this slide, I just tried to throw together a lot of the things that have, you've probably heard about. They've been bannered about in the media. They've been on all the healthcare provider forums and so forth. But you see things here like elderberry and other botanicals, like andrographis, artemisia, nutrients and on botanicals like EGCG, all of your polyphenolic antioxidant plant-based materials. And that would include EGCG, resveratrol, quercetin. All these things can be remarkably beneficial, and we'll talk briefly about some of the reasons why in a minute. We talked about IV vitamin C, but things like tocotrienols, particularly delta fraction tocotrienols, can be very, very helpful in viral infections because they sit on the inside of the cell membrane, where, for instance, quercetin sits on the outside of the cell membrane and blocks viral docking and fusion. So it kind of blocks the penetration of the viral genome into the cell, so it will not be hijacked. Vitamin D, we're going to talk about briefly, and even things like low-dose aspirin. So, but this created a lot of controversy out there in the media, as you know. There was a lot of really positive stuff that was coming out on all these different natural agents, and then, as predictable, behind it were all the warnings, all of the, you know, kind of dampening down the enthusiasm. And I think there were a lot of different economic, market, and political forces behind that, which we don't have time to get into, but you probably all heard, got emails, got, you know, texts and private messaged from people, in my case, people I hadn't talked to since high school that kind of found out or know what I do, and I'd be getting text or PMs saying, hey, Should I stop my elderberry so I don't have a cytokine storm, right? Should I stop ibuprofen? And all these different things. And it prompted me to actually write a blog and place it on a lot of the integrative functional medicine and nutrition forums around the net. And I titled it Cytokine Storms, Elderberry, Ibuprofen, and Tylenol, oh my. It was like, you know, it got just crazy. And I was probably like many of you answering the same questions 200 times a day. So I finally kind of wrote a little bit of a piece about it that just sort of vented a bit, and that's why I used this graphic. So if you saw it, you know what I'm talking about. If not, I'm sure you can find it out there. But you know, the whole issue of elderberry, for instance, was ridiculous. Elderberry has been studied for eons. It's been used for eons. It's been studied extensively in modern Western construct as well, including for viruses in influenza particularly, but there's data on it in SARS-1, there's data in MERS, and consistently it's provided benefit to some degree. But elderberry, as most botanicals, it's a very complicated structure, right? It's a very complicated compound with a lot of different actives in it, and it actually increases some anti-inflammatory cytokines, and it increases some inflammatory cytokines, but it has a net sort of balancing homeostatic effect on the immune system that lends it away from entering a cytokine storm, lends it away from an overreactive kind of posture. And that's been clearly elucidated in the literature. And when they even looked in influenza models, what did elderberry do to pro-inflammatory cytokines? It only had the ability to upregulate the cytokines, different ones at different levels, but the highest they ever saw it really increase an inflammatory cytokine was about 4 to 6 times normal. Keep in mind that in cytokine storms, your inflammatory cytokines are thousands of times normal. So, you know, to say that your elderberry was going to cause a cytokine storm was kind of like saying that the car hitting the train was going to result in a great deal of damage and the derailment of the train. It's just not going to happen. The orders of magnitude of force on what's going on there are not even close. So the whole idea of stop your elderberry, it'll cause a cytokine storm, was kind of ridiculous on its face if you knew anything about the literature. But once again, every time something really positive came out on a natural agent, or I may also say when positive stuff came out on a pharmaceutical agent that was an old pharmaceutical agent that was already generic, it got shot down as well. So I'll leave it to your own devices to figure out in your mind what you think was going on there. But let's stick to the literature. A review of micronutrients in the immune system, if you do even a cursory one, you'll be met with a plethora of information on exactly how different natural nutrients modulate the immune system in various ways, including vitamin A, D, C, E, B6, B12, folate, zinc, iron, copper, selenium, on and on and on. And probably those with the most heavy weight of evidence, now some of it's maybe because they've been studied the most, is vitamin C, vitamin D, and zinc. So we'll talk a little bit about those. And some of the most striking stuff to come out during this whole episode of this pandemic has been the performance of vitamin D. And I'm sure you've seen a lot of the different papers emerge, first out of China, then out of Korea, then out of Indonesia, showing that, first of all, high-dose vitamin D3 administration was associated with better perfusion, increases in hemoglobin concentrations, better outcomes in ventilated critically ill individuals. And then we started seeing information on mortality being decreased significantly in people with higher vitamin D levels. And in fact, then later on, better quality peer-reviewed literature started coming out, really backing up what was first said. And this is a great paper to pull and read, The Role of Vitamin D in the Prevention of Coronavirus Disease, Infection, and Mortality. So you notice this even mentions the word prevention of coronavirus disease, not just changes in outcome and mortality. And in fact, the data sets that have been developed are amazing, where if you plot the average levels by population of 25 hydroxy vitamin D3 in the population of each country and look at mortality, it's pretty evident that the countries with the higher levels of vitamin D in their population have much less mortality than those with lower. But beyond just mortality, you can plot the data in a similar way, plotting the vitamin D level in the population at mean against COVID cases. So remember, COVID-19 means you're developing the clinical syndrome, the respiratory kind of sequela, classic of what we know drives people into the hospitals when they have SARS-CoV-2. But most people with SARS-CoV-2 do not develop COVID-19. So this is being affected, apparently, at least in this statistical model, by the level of vitamin D, which means populations with higher levels of baseline vitamin D would therefore likely repeat this data, where they would have less likelihood of clinical COVID-19. Then you have your plant polyphenolics. These have an interesting structure to them that allow them to work on a multitude of mechanisms against viruses, but particularly in blocking viral docking on host cells and penetration of those cells. Quercetin is one of them. Quercetin has an amazing amount of data behind it, studied in influenza models, significantly so, but also in SARS-1 and in MERS. And the quercetin data is almost too much to even list. It's a very potent antiviral agent, particularly apparently when combined with vitamin C. So quercetin ascorbate powder is like, frontline pharmacy stuff for me right now with anybody who either we know has been exposed to SARS-CoV-2 or is interested in preventing COVID-19, or patients of mine who've actually had COVID-19. Other plant polyphenolics like resveratrol have been studied extensively in MERS. There's some preliminary data in SARS-CoV-2, but of course it's early. We've not had the time to really study these things and have a lot of retrospective kind of assessment of how they're performing. But coronaviruses, generally act like coronaviruses, and there's a lot of, commonality in them. There's some particularly unique or novel trickiness of SARS-CoV-2, but we have no reason to think that the immune system is going to react entirely differently to SARS-CoV-2 than other similar coronaviruses. Andrographis and other herbals have had great preliminary data from China, even in SARS-CoV-2 and COVID-19, but certainly lots of conventional use or traditional use, I should say, and a lot of data in related viruses, including other coronaviruses, influenza, MERS, SARS-1. And the Chinese immediately started basically screening everything and putting just about everything into human clinical trials directly in their hospital systems, including traditional Chinese medicine preparations. And as most of you on the call probably know, studying traditional Chinese medicines is a bit difficult from the Western construct because they generally have more than one herb in them. And each herb is a complex compound in and of itself, but they have emperor herbs, synergistic helper herbs, and all those different things. So there are these sort of patent formulas, but if you just take them as they are and study them for outcome, there was a tremendous amount of these traditional Chinese medical patent medicines that perform very, very well, specifically in SARS-CoV-2. Glutathione therapy in relieving dyspnea in COVID-19 associated pneumonia was out almost immediately in case studies and then in some larger trials as well. But even nebulized glutathione, been using it with oxygen therapy with many of my patients with great success. And then, of course, when we had the antimalarials, antiparasitics popping on the radar, basically out of the experience with Ebola in Africa, where it was really the only agents that seemed to do much. So when they threw it at SARS-CoV-2, when most of the antivirals really didn't work, particularly the new expensive ones, they found things like hydroxychloroquine and chloroquine, which you heard so much about in the media. A lot of it was A lot of it was financial, political, and many other things. And there was fault on both sides of the argument. But it's a well-known antimalarial drug. It's been around forever. But there are botanicals that have very similar mechanisms of action and are known effective antimalarials, including Artemisia. So Artemisia with artemisinin in it is actually very effective against a range of coronaviruses and is an obvious choice to use in COVID-19 and or just SARS-CoV-2 infection. Now, before we pivot to lab testing, I just wanted to, though, mention that because of the predilection to ACE2 receptors and because of the importance of the ACE2 rich receptor-rich tissues to the body, it would be kind of logical that we would see significant effects on the cardiovascular and respiratory system, not only just in a short-term basis, but longer term, and to have worse outcomes on people who go into the infection with pre-existing cardiovascular disease, which could include hypertension, could include respiratory disease, could include any kind of myocardiopathy and things like that, and that certainly proved to be the case. But what is really interesting is people seem to have been infected with SARS-CoV-2, had no cardiovascular histories, and yet come out of it even after any acute respiratory infection with signs of rapidly emerging cardiovascular disease. And this happened also in SARS-1, if you go back and look. With 12-year follow-up surveys, this is, this particular one I'm citing was only 25 patients who recovered, but a much higher percentage of them went on to develop things like hyperlipidemia, and cardiovascular system abnormalities and glucose metabolism disorders than people who had not been infected with SARS. So we may be seeing this going forward with a lot more cardiovascular and respiratory chronic symptomology in people who had otherwise been perfectly healthy before they got infected with SARS-CoV-2. And, the thing that's really more current that's been being understood a little bit more every day is the effects of the virus in the vascular system. It became apparent pretty early, although the medical system was slow to act. They were treating critically ill patients in ICUs that had low oxygen saturations, like they had run-of-the-mill viral pneumonia, and they sent them through those routes of care with those kind of protocols, if you will, quick to ventilators. That turned out to be not a very good idea. In fact, the ventilators caused more damage in these people's lungs than it really helped them. And in fact, this virus, even though it's thought of even today as primarily a respiratory virus, I think in the end, when history is written, it will be thought of as a vascular virus, or a endothelial attacking virus. So, and you're seeing data coming out of Israel, out of Hadassah University and Medical School recently, talking about these, COVID clots, if you will. And you've heard about COVID toes. We've known about the effects on the kidneys and in other areas due to these micro clots. And we've thrown baby aspirin at it. People have thrown fish oils and SPMs at it. And I think that was a good thing to do. Nattokinase, serrapeptidase in the natural realm. I think those were all really good things to do. But using your classic, commonly used blood thinners, anticoagulants may have helped a bit, but did not seem to really get the job done as they were hoping that it would. And we may have a little bit of an idea why that was the case now. These researchers in Israel have found that the people who get these fatal clots have much higher levels of alpha defensin protein in their blood. And alpha defensin protein can facilitate this kind of clotting phenomena that we see. And you see this quote here: patients with mild symptoms have a low concentration of alpha defensins, but higher than normal control people. Patients with strong disease symptoms like flat out, serious COVID-19 have high levels of alpha defensin, and people who die have very high levels of alpha defensin. So you get into sort of a bit of a chicken and egg question on that. But we do know that about 80% of coronavirus patients who were intubated, put on ventilators, died. So, you know, usually if we're doing a certain protocol, a therapy, an intervention, and 80% of the people are dying, we usually rapidly stop doing that. That didn't occur rapidly with COVID-19. It's happening now. It's happening quietly, but it's definitely happening now. And what the Israelis found is they were looking for agents that might be able to reduce alpha defensin. And they turned to another old drug, long off of patent, which has long been generic, which is colchicine. And colchicine is used for gout. Basically, it's an old anti-inflammatory that has blood thinning effects as well. They've done some extensive trials with it very rapidly in rodent models and are transitioning it to human therapeutic outcome trials right now. But it's interesting that some of these old tried and true drugs are the ones that are kind of performing. And it was interesting to see them being sort of talked about and then immediately squashed down. But I think it's kind of, I think this whole thing has made a sticky impression on the public. I think we went into this pandemic, they realized very quickly there was no modern magical pharma, bullet to save them. There was no vaccine. There probably wasn't going to be a vaccine very quickly. Doctors closed their offices. The only way they can get care was to go to an emergency room, and it was probably the last place they wanted to go. They really had to turn to trying to research how to take care of themselves. And a lot of them went out, and with the internet, they discovered a lot of things out there that they never looked before. And they started seeing all the data that's out there on natural agents, whether it's botanicals, IV vitamin C, lauric acid, zinc, all these different things. And the public turned to them in droves. And if you don't believe me, you've probably seen all the back orders that were going on a month ago in the nutraceutical industries, because everything immune related in natural therapeutics was just being ripped off the shelves. So I don't think that's going to go away very, very quickly. I think it's going to change people's perception that, hey, maybe the stuff really is real. Maybe it does have therapeutic value. Maybe when it's, just brushed aside, that there's some other reasons why it's brushed aside so quickly, and it doesn't have to do with its efficacy or lack of efficacy. So in summary, just about the virus, it's about 1,000 times more infectious than SARS-CoV-1. And we need to try to better understand who's likely to go down this bad trajectory. And we have a lot of things in our natural therapeutic, bag of tricks to be able to help. Melatonin, vitamin C, particularly high dose IV vitamin C, but many of the other natural agents that we talked about. Now, it was about the busiest 2 months of my life, because on one side, I was trying to keep up with, immune therapeutic agents being, manufactured safely in plants with employees that weren't, infected, trying to make this stuff, keep it going, make new immune products on the therapeutic side. But on the diagnostic side, we really, really had our hands full, because we all know kind of how the testing thing, rolled out in the beginning. The ball got dropped by CDC. They didn't use the WHO kits. They made their own kits. They didn't perform well. They didn't distribute them in the right way. So they really had to very quickly pivot to the private sector to kind of bail the situation out. And what was needed to test for COVID-19 was really a very specific, very high fidelity molecular approach to find this virus specifically. And our team at Diagnostic Solutions Lab, we're basically a high-level complexity molecular shop. That's where our forte is. That's where our science team is mainly built, with some amazing people. And we were able to pivot to that very, very quickly, and even taking people off many other critical projects and putting them just on trying to come up with the initial COVID-19 diagnostic test. And we did so. The original CDC test, which didn't work very well, by the way, didn't find the two M protein targets it was looking for well. So when we went to work on it, we targeted those same two M proteins, but were able to do it with very high level of fidelity, but also targeted two other proteins, a spike protein and an envelope protein that were novel to SARS-CoV-2, getting our validations to FDA. And we were in the first batch of labs that were authorized through the EUA by FDA to perform COVID-19 diagnostic testing for hospitals, academic centers, and so forth. So you see the FDA website screenshot here with DSL circled. We were playing in the game here with the highest level academic medical centers of excellence, pathology labs, major clinical labs like Quest and LabCorp and so forth. Although at the time, in the beginning, especially for the first month or two, the turnaround time for some of those big clinical labs was like 11 days. So by the time you got results, it really didn't matter anymore one way or the other. So we were very, very early in this, and I'm really proud of our team for being able to do that. We were really the only laboratory that came from the integrative and functional space that had the scientific might and technological prowess to be able to pull this off. And it was very much noticed by FDA and other regulators. And in fact, when we in parallel developed our stool test for SARS-CoV-2, FDA now is recommending every fecal microbial transplant program to DSL for screening of the material before implantation for SARS-CoV-2 by DSL. So, we rolled out very early with the COVID-19 diagnostic test, which is a nasopharyngeal swab. It's a molecular test. And then soon after onboarded antibody testing and stool testing for SARS-CoV-2. So before we go to Q&A, I'll just give you a real little primer on the three different test options. One is the COVID-19 diagnostic test. This is the molecular testing on the nasopharyngeal swab. It's a quad-targeted molecular profile with a super high degree of sensitivity and specificity to SARS-CoV-2. This is an example of a positive in a patient. This is being performed for hospital systems, healthcare plans, drive-through testing centers, and basically institutional and public health type of clients. And we've been doing this for a long time. We're processing thousands of them a day, and we've been doing so since the very beginning. So we've been able to collect a lot of data and work with these large hospital partners to understand the clinical histories of the patients who they're sending in samples in, so that in parallel, we were able to develop the IgG/IgM antibody testing. So it's really critical to have a clinical comparative point. So having positives, known positives and known negatives in PCR nasopharyngeal swab testing and clinical histories on patients, and then also getting the serum sent or the plasma sent to do antibody testing allowed us to not only rely on the validations done by the kit manufacturer, but then do our own internal validations to the clinical information and the PCR results from the nasopharyngeal swabs. So here you see an example result on a patient where they had IgG titers detected above the threshold considered consistent with immunity, and negative for IgM. So this would be the kind of result you'd see on someone who had been exposed maybe weeks or months in the past, but does not have an acute active infection, but has sticky immunity to previous exposure. This is the kind of result you want when you do an antibody test. And then the SARS-CoV-2 stool test is basically the same quad targeting real-time PCR molecular testing done on fecal material, which has advantages because the patient can collect the sample at home. They don't expose the healthcare provider if they're infectious. So you don't need to have a healthcare provider garbed in PPE to collect the sample. You don't need to stick a big swab, almost into their brain to get the sample. It's just collected like any other stool sample. And it's really good for community surveillance. It's good combined with antibody testing as you're managing patients at home through telemedicine, for instance, to really kind of find out, have they been exposed? Might they be shedding? Might they still be a vector to those around them? But just even though this uses the same molecular real-time PCR quad targeting, it's not technically, according to FDA, a diagnostic test for COVID-19 because COVID-19 is a respiratory expression. So it has to be on a respiratory sample. But SARS-CoV-2 in the stool means you've been exposed and you are likely shedding in the stool. We are learning more and more about SARS-2 integration with anaerobic bacteria in the microbiota, such as Prevotella species, and how it helps do its dirty work and helps pull iron out of the red blood cells. It changes perfusion, changes the person's ability to maintain oxygen saturation. And we are studying that right now in the lab by having parallel samples. It's an advantage of having a lab that's doing the NP diagnostic swabs, the antibodies, and the stool, because we can kind of triangulate on these three tests in many common subjects with clinical histories. If you want to learn more about the stool test and how you might be able to implement it in your practice, on the DSL website in the educational section, so if you go to diagnosticsolutionsLab.com, click clinician, and then education, and then educational articles, you'll see this really nice white paper done by Tom Fabian, one of our brilliant PhDs, and Cass Nelson Dooley on stool testing. And then I did write a comprehensive white paper and article on COVID-19 and SARS-CoV-2 testing and clinical implication of the testing and the differences between the tests, the pro and cons of the different styles of tests. It was published in NDNR. It was also published in the Townsend Letter this month, but it is available for you. If you want to just download the full PDF of it, you can just go to the URL shown here, just to my website, drdavidbrady.com/COVID opt-in professionals. You can see it there. You can download it in full PDR or PDF. If you just want to read it, you can go to also to the DSL website, to the education articles section, and you can access it there. So with that, I'll turn it back over. We can talk about some questions and answers and wrap it up from there.
Excellent. Thank you so much for that information, Dr. Brady. It was very, very thorough. We do have a couple of questions here. Actually, I'll start with a couple from our attendees.
Okay.
One of the questions is, how long after infection is the stool test valid? For example, if someone were infected a long time ago, will the stool test still detect the virus?
Yeah, that's a good question, and the answer is still being definitively determined, but we know from at least the preliminary data. What's interesting about the SARS-CoV-2 virus in the GI tract is that you can find it with molecular targeting, like we're doing, generally before you can find it in the respiratory system. So even if someone goes on to develop some level of COVID-19 where you can get in a viral lobe on an MP swab or on a viral or on a lung washing or a lavage or an oral swab, whatever it may be, you can find it before in the GI tract if you look. You'll get a viral load sufficient enough in the stool before you'll find it in the respiratory system and afterwards. Even after someone has respiratory illness related to SARS-CoV-2, if they recover, we still find it in the stool up to 6 weeks out from when they were first infected. So it persists in the GI tract far longer than it persists in the respiratory system. But as far as we have data right now, we know it can be there at least 6 weeks after infection and shedding for 6 weeks. But in some people, it probably sticks around significantly longer than that. Exactly how long? I think it would vary from individual to individual, and we don't definitively know yet.
Okay, excellent. Another question that has come up is, let's see, in regards to, where did that go? Okay. There we go.
It's hard when there are those chat boxes, huh?
Yeah, the text get a little small. Is there a supposition that antibodies may disappear after 2 to 3 months in many? Are there any studies on that and reinfection, which was another common question that's come up? Obviously we're dealing with what we're learning as several variations, of the virus. So how many are we looking at? And do you anticipate that we'll be seeing more mutations that would make reinfection more likely?
Well, listen, these are all really good questions, and they're, again, I keep saying the same thing. They're not definitively answered because this is a novel virus. It's a new infection, and what we're used to knowing about infections and viruses comes out of a long retrospective study of these pathogens as they've been around, and we've seen how they interact with people's immune systems. Right now, we're going on a lot of sort of assumption on what we know about immune responses and coronaviruses in general, to a large degree what we learned from SARS and MERS, and what we've been able to learn so far in a limited amount of time from this specific virus. From what we see, most people who are exposed certainly go on to develop a fairly rapid IgM spike, which in antibodies, which of course then starts ramping downward as they get seroconversion to IgG. They generally produce enough IgGs to pop on a quality antibody test that's done with a good ELISA kit that has a good sensitivity and specificity. And how long the IgGs last, how high they spike in titers is extremely variable. And it is in general in viruses, not just this virus, because it depends on your specific immune response. It also depends on the level of exposure to the virus you had. So your peak viral titers will often determine how high your antibody titers go in response. But there's also another phenomenon at play, which is the persistence of your exposure. For instance, if you're exposed once to one individual and you get a certain viral load from that, that's very different than if you're a healthcare worker and you're being exposed repeatedly on a day in, day out basis to people with the virus in a hospital environment. You will develop much higher and much more persistent immune titers in the latter scenario of being a healthcare provider. So all of these things, and we saw this phenomena play out because a big part of what we were doing in our antibody testing at DSL was testing the medical staffs of our large hospital partners for which we were doing the NP diagnostic swabs for COVID-19, because they wanted to know who to keep on the service and who to take off the floor. So we saw this kind of effect at play. But, what we've seen so far is pretty predictable for coronaviruses. The IgGs will persist over time. They will decay, different rates of decay in different individuals based on their unique immune tendencies, but also their viral exposure. But it's pretty apparent that there is definitely sticky immunity to the virus. We do not have hard evidence of reinfection, really, of anybody with SARS-CoV-2 and COVID-19 to date. There were some reports of that out of Korea and things like that. It turned out to really not be substantiated. We don't know if that will happen, and if it does, when. It will depend on a lot of things. We know that coronaviruses in general, just like influenzas, they mutate, they change. That's why the whole idea of a vaccine is really iffy. They've never really developed a viable static vaccine for a RNA virus yet. There's no reason to think they magically will. They tried to, there was many vaccine initiatives for SARS-1, none of them were successful. And even in influenza, it's not one of those, vaccination programs where you get it once or you get a couple boosters and you're good. If you're going to get flu shots, you got to get them all the time. They're predicting what's coming next because these RNA viruses tend to be rapidly changing, and they change enough to where, over time, you just don't have the immunity anymore and you're susceptible to another infection. If that happens with this virus, It wouldn't be surprising, although some evidence says it may not, because this virus has a very, very complicated and long genome compared to other coronaviruses. And part of that genome includes a lot of reparative mechanisms and the ability to encode for reparative enzymes. So the genome does not change as rapidly as other coronaviruses. Therefore, it is not as susceptible to significant mutation. In fact, a lot of people talk about mutations of the coronavirus, but if you really read the virology literature, to people who really know what they're talking about viruses and how they behave, they've not yet identified a mutation of the SARS-CoV-2 virus. They've identified isoforms of the virus, which means there has been changes in the genome of the virus as it was seen first in China versus then in Italy versus then in the UK versus then in the US. But a mutation technically means that there's enough variation in the genome to create a functional difference in the way the virus behaves or the way the immune system reacts to it. We haven't seen that yet. We've seen mild changes in the genome where we can tell little differences between different strains, if you will, of the virus in different locations, in different outbreaks, but none of it yet has been fundamental enough to change how the virus behaves and how the immune system behaves to it. Therefore, there's technically no mutations, if that makes sense.
Okay, excellent. So, speaking in that vein, Dr. Brady, what would you say in terms of, some of the emergence of people who are testing positive multiple times? What would you speak to that?
Testing positive multiple times on NP swab for diagnostically for COVID-19 or with antibodies?
I guess with either, if you want to speak to, I would say that either would be applicable.
I don't really know of anybody, any studies showing people testing positive on NP swab or respiratory sampling diagnostically for COVID-19.
Okay.
There's been people certainly who've tested negative for antibodies, then positive for antibodies, then negative for antibodies, then positive for antibodies if they just do a bunch of serial tests. That's because there's much more variation in antibody testing than there is in molecular testing diagnostically. So,
Sure.
And antibody production is much more fuzzy around the edges. It's much more variable individual to individual, and there's a lot of variations in the types of testing and their quality. So we have rapid testing, we have blood spot testing, we have, full-on phlebotomy testing with really high quality ELISA kits that have a high degree of sensitivity and specificity. They're very different animals. They require a much different level of viral exposure and subsequent antibody production titers to hit the threshold of that lab and that kit for detected or positive or negative. So that's more test variability. That's more where they're making their cuts and their calls for what's positive and not. That's the phenomena you're seeing there, not so much as people being reinfected.
Okay. And another question that came in was about some of the different results. I believe that a couple of the attendees have done testing through your lab, and some of them have gotten high results versus low values. Can you speak to that a little bit?
High versus low in
results for the antibody results, correct?
Well, we report our antibodies basically as detected or non-detected. Detected or non-detected really depends. Are you hitting it's a quantitative test in the background. Okay, so we're quantitating the titers, but in the validations of the assay and of the test, you have to come up with cut points on where you're making the call that detected means the antibody titers were high enough to be consistent with an immune response that would confer immunity. Okay, so detected means you hit that titer threshold that it's a positive, if you will. Non-detected means you did not. So if they're getting a detected and then a non-detected later on in the same test, repeat it, or the other way around, it may have been enough time where you either had seroconversion from IgM to IgG, or if it was an IgG detected that later on was not detected, that person may have rapidly declined in their IgG titers over time and went below the threshold. So it's hard to say exactly what was going on in a case, but those are all potential variables that can be in play in antibody testing. And listen, this isn't new. This is immunology testing. Immunology testing is way fuzzier around the edges than other types of testing because of the inherent dynamics and the complexity of the immune system.
Sure. All right. Well, we are getting close to time here. I'm going to just ask one more question before we wrap things up. What is the best timing for testing? When would you suggest retesting? Is it recommended? Is it necessary? What are your thoughts on that?
Well, if it's pertaining to diagnostic testing for COVID-19, generally what triggers a test most commonly is symptoms, right? So someone has some sort of respiratory symptoms, shortness of breath, fatigue, low saturation levels, whatever it may be, you're getting a test done. The peak viral load on NP swab is usually anywhere from 3 to 5 days, even up through 7 days after symptoms begin, and then it rapidly starts to decay. So the real limiting factor on diagnostic testing is not the laboratory. The molecular targeting of this virus is pretty spot on with anyone who's doing real-time PCR. The limiting factor is getting enough viral load on the swab. So that comes down to technique of collecting it and the timing of collecting it, how many days after. So it's a great question. So from symptomatic onset, 3 to 5 days is your ideal window. Now, if someone tests positive, then they're obviously going to go into a quarantine situation, whether they're in a medical facility because they're acute enough, or whether they're sent home. They're going to convalesce there, and hopefully, if they're have any kind of interaction with providers like us, they're going to be getting a lot of supportive therapies over the course of that time. But generally, they're going to be, in for a 14-day duration, and you want to test at the back end of that. So often, to release them out of quarantine, it varies by jurisdiction, but different public health entities, public health departments, once you report the positive test, you'll be in quarantine for 14 days, and most of them want a repeat negative test before you leave quarantine, certainly before you go back into general society and work or anything like that. So you usually would repeat it at 14 days. And we've had people, even at 14 days on retests, still were positive. But if we go behind the scenes, we look under the covers and at the quantitation on the level of viral load we found, it's usually significantly lower, but it still may meet the threshold to be a positive. So in that case, you wait another week and you test again until you get a negative test.
Mm-hmm.
With antibodies, usually you're going to get an IgM spike within a week to 2 weeks of symptoms, and you'll get seroconversion, and then you should have IgMs going down and IgGs popping up, within 2 to 4 weeks. At the 4-week point, usually significantly, you're into that pattern, and then that pattern will persist generally for several months.
Okay, excellent. Well, again, thank you so much for your time, Dr. Brady, for all the insight and information that you shared with us today. We're a little bit over time, so I'm going to wrap things up. Please note, if we didn't get to address your question during today's webinar, or if you do have questions that arise after the fact, please contact us. You can see our contact information here listed on the screen. Let us know how we can get you some answers, provide additional support. Also, many of you have already asked. We will be making this webinar available probably sometime next week. So let us know if you are interested in the link. We'll make sure that is sent out via email. Again, thank you everyone for your time this evening and attention regarding this very important topic. And until next time, stay healthy, stay safe, and know that we here at Evexia wish you all the best on your pathway to wellness. Take care, everyone.